In type 2 diabetes mellitus, there are two possibilities: that the amount of the insulin is not sufficient, or second, more important, that there might be insulin resistance, that the cells may not accept the insulin to open the cells, that the glucose can enter into the cells. So that is first thing. We also know from biochemistry that there is a cutoff value of 126. Okay? 126 marker.
Wow. Behind me.
Yes. Okay, well, I understand. One 26 milligram percent or per day or per deciliter. This is the cutoff value. Okay? Cutoff value means if we cross or the patient crosses this number, the patient is diagnosed with diabetes mellitus. And this is what we are talking about: fasting plasma or blood glucose level. Fasting means that the patient will be nil by mouth for at least 10 to 12 hours. Okay? So that is first thing. Anyone that is from 100 to 126 milligram per day. Who is this? Pre-diabetes. This is pre-diabetes. Why I am writing here? Because it will help us when we will discuss the uses of metformin. This is second category. This condition will be called hyperglycemia. Hyperglycemia. Okay? So, the advice is that we should repeat on two separate occasions. For example, today is Wednesday and the date is 15/05/2024. Advisable that after 10 days, like 25/05/2024, repeat fasting. Repeat fasting. Okay? Again, the value is more than 126. First thing that we will do, that we will ask the patient what we say counseling, that you are suffering or you are the candidate for type 2 diabetes mellitus. You are suffering from hyperglycemia. Now, you should say goodbye to sugar, goodbye to caffeinated, carbonated, citrated drinks, Mafi, Pepsi, Mafi, anything like this. Okay? And lifestyle modifications. Start walk, exercise, weightlifting, keda. Anything that he can do easily, that should be the advice. If this advice doesn't work, or he is failed for some reason, next step will be we will start treatment. Now the treatment in this case that you will see inshallah in your patients, almost 95% patients with type 2 diabetes mellitus, they will be receiving metformin. They will be receiving metformin. This is very commonly prescribed medication, especially where there is the patient is overweight or obese. Now they say instead of overweight and obese, high BMI. If the BMI is more than 28, 30, then they say that the patient is obese or overweight, whatever you say. Mechanism of action, you again discussed with Dr. Fathi that it will activate AMP, activates 5
AMP.
AMP protein kinase, adenosine monophosphate kinase, that is part of the ATPs. ATPs are
Adenosine triphosphate.
triphosphate, that is the source of
Energy.
energy. The whole biochemistry that you discuss, by end you go for the ATPs, whether it is lipids, whether it is proteins, and definitely carbohydrates. Whatever is going in the cycle, by end you get how many ATPs. Here, it will activate this enzyme, and this enzyme will block very important process that is called gluconeogenesis.
Neogenesis.
Neogenesis. Okay, so it is a protein that responds to increased stress and energy demands. As we discussed, energy demand is ATPs. Okay? Now, energy demand means that the body needs more ATPs, whether the source is carbohydrate, whether the source is protein, or whether the source is lipids. That is the first thing. Second, it will stimulate peripheral glucose uptake. If you remember last time we discussed, all body organs and cells need energy. But 3 organs, they are more important for the insulin.
Okay.
Insulin. Brain needs energy by any means. Even if you see the case that you discussed in PBL, why the gentleman suffered from diabetic ketoacidosis, because ketones start to help give energy. Brain needs energy, but 3 organs, they are insulin dependent. The energy source, the key is with insulin. Liver,
Kidney.
muscles,
Brain.
and adipose tissues, fats. Liver, muscles,
Adipose tissue.
adipose tissues. So, fatty acid oxidation, your favorite biochemistry. Fatty acid oxidation also leads to gluconeogenesis. In the cycle, when you look back to the cycle of the fatty acid, that will also give us energy or ATP. So, what it will do, first thing, that it will stimulate peripheral glucose uptake. Peripheral glucose uptake, especially muscles and adipose tissues. It will help that the cells should open. Which cells? Muscle cells, and the second one, the adipose tissues, to receive the glucose. So that is called peripheral glucose uptake. Second one, it will inhibit liver gluconeogenesis. It will block the gluconeogenesis in the liver. Here, what I told, fatty acid oxidation. When the liver cannot synthesize from the carbohydrate source, then what it starts to synthesize it from non-carbohydrate source, and one of them is lipids. So it will also block or reduce the fatty acid oxidation. So that is second mechanism. Third one, increase the insulin sensitivity. It will help the insulin to act effectively, like in the muscle cells, in the adipose tissues, and even in the liver. The insulin that is present, it should act actively to open the door for the glucose. So peripheral glucose uptake by reducing gluconeogenesis, including, you can write in bracket fatty acid oxidation, and the last one by increasing the insulin sensitivity. Now look here, it has no direct role in the insulin secretion. All the mechanisms that we discussed, it has nothing to do with the insulin secretion. Whether the beta cells are good or bad, whatever is present, the insulin that is present, it will utilize that insulin. So, what is the best benefit that we get out of it? That it will not cause hypoglycemia. Here we discussed that the situation, if the blood glucose level is more than 126, that is hyperglycemia. One of the very important side effects, as we already discussed in insulin, that is hypoglycemia. And all other groups except metformin in oral doesn't cause hypoglycemia. I don't know whether Dr. Fatih told you 60 or 50 milligram per deciliter. 50, 60 depends in the situation. Okay, so that is first thing. Where do we use metformin? Again, this is the drug that you will see in your clinics. Patients are using very commonly who are suffering from diabetes. First one, pre-diabetes. Patient is overweight and the glucose level is from 100 to 126. We can start with metformin. Then we have, that is the most important thing, first line type 2 diabetes mellitus drug. Any patient, if there is no contraindication that we will see, we will start in type 2 diabetes, the first drug, metformin. We will start with metformin. Then weight loss in type 2 diabetes. As we discussed, one of the reason for type 2 diabetes mellitus is high BMI. Overweight or obese people, they suffer more from type 2 diabetes mellitus. Why? Because insulin resistance. Insulin doesn't work to open the cells. Okay, so that it will also help us to reduce the weight. Why it reduces weight? Because it suppresses in the hypothalamus hunger station, as we discussed previously also. So it send message to the hypothalamus, don't need any food. Don't send any food. So the patient says, I feel satiety. Satiety means fullness. And sometimes nauseation. Nauseation, you understand, when you likely to vomit. So the patient feel like this, so the patient cannot take food. So that is good thing about this. There is, all these are called diabetes associated the uses of metformin. There is one non-diabetic use of metformin, that is called polycystic ovary syndrome. So that means that the patient is female. The patient is female because ovaries are only in females. What happens that there are many cysts, polycystic syndrome. There are many cysts in the ovaries. And again, one of the reasons is considered to be insulin resistance. Insulin resistance. There is another very important thing. If you Google, you will find, check it, acanthosis. Please check it, ACANTHOSIS.
Benign thickening of the brachial cell layer.
Yeah, if you check the images, it will help you.
Oh,
yeah, especially here on the back side.
Backside of the neck.
Yeah,
Yes.
even you can tell the patient that you are suffering from insulin resistance. You will see the picture, image, yeah, like this. And that it can even increase. First it comes here, then here, then here, and then go down. Everywhere it will go. In the foldings, it start to appear. That is due to insulin resistance. And in females, mostly when the patient is suffering from polycystic ovary syndrome, this symptom appear. You see, insulin resistance. What are the side effects? First one, modest weight loss. Weight loss is good, but for example, if the patient is already thin, thin, so that patient doesn't need weight loss, but that is not very common. Second one, rare lactic acidosis in renal failure. So that is the most important thing that you will keep in mind. We use metformin in all diabetes patients, type 2 diabetes patients, except renal failure. If you get question on your exam that, for example, Ismail was renal failure patient or renal impaired patient, which of the following is contraindicated? So the answer should be metformin. We don't use metformin in renal failure. What is the problem? Lactic acidosis. What is lactic acid? Anmar. Dr. Fatih says Anmar is very good in biochemistry. Marra mazboot in biochemistry. Lactic acid.
End product of anaerobic.
End product of anaerobic. End product of anaerobic.
Must afford
Good thing, bad thing?
bad.
Bad. But it gives us energy.
Energy in muscles. Yes.
In muscles. Yeah, but it is the end product of the cycle. What happens that the body produces it and it goes to the kidneys and it goes out from the body. In case of metformin, metformin blocks the lactic acid. Metformin blocks the lactic acid, so it accumulates in the blood and that leads to lactic acidosis. But in which condition? If the patient is suffering from renal failure.
Okay, doctor, so the question will be patient with renal failure and diabetic at the same time.
Yeah.
Which drug will be contraindicated?
Contraindicated, metformin. Okay?
Okay.
Last one, because it inhibits the mitochondrial enzymes which are required for the lactic acid metabolism and excretion from the kidneys. Last one is significant diarrhea. Significant diarrhea.
Diarrhea.
What happens that, inshallah, when you will go for postgrad education, you will find any patient who is suffering from diarrhea, especially children, they are advised to say stop sugary things. Why? Because glucose or sugar promotes diarrhea. Glucose or sugar promotes diarrhea. So metformin, it increases the excretion of glucose through feces or stool. It sends more glucose to the feces, to the large intestine, so the intestinal motility is increased. Why? Because glucose causes osmosis. It causes osmosis in the intestines and that can lead to diarrhea. So sometimes we stop this medication due to diarrhea. Sometimes. Mostly patient can manage because we start with very low dose of 500 milligram and we can go up to 2500 milligram. 500 milligram start and maintain at 2500 milligram. So big dose, what we say optimization or titration of the dose. Gradually we increase the dose. If we instantly start with such big dose, definitely there will be
Significant diarrhea.
diarrhea.
Okay.
Okay, go to the next.
Sulfonylureas.
Sulfonylureas. Sulfonylureas, they are the second after insulin. They are the second after
Insulin.
First insulin came, and then in 1950s or something like that, sulfonylurea came. There are two generations, first generation and second generation.
Okay.
First generation is no more used clinically. Chlorpropamide, tolbutamide. But one thing that you need to understand, you can write in bracket, first generation is longest acting. They are longest acting. The duration of action in days. The half-life is in days. The half-life is in days. It is not a matter of minutes or hours. It will continue in the blood maybe for 2 days, 3 days, 4 days, like this. Tolbutamide and chlorpropamide. First thing. Second thing, for these first generation, the dose is in hundreds and thousands. 100 means, for example, the dose is 500 milligram. The dose is 1000 milligram. The dose is 1500 milligram. The dose is 2000 milligram. So this is hundreds and thousands. The dose is in hundreds and thousands. So the message is long acting, less potent. Try to understand. Long acting but less potent. Less potent means larger dose is required. Larger dose is required. Second generation that are nowadays very commonly used are like glyburide, glimepiride, gliclazide, so many ides are there. They are moderate acting. You can write in bracket, moderate acting. The action is in hours. The half-life is from 8 to 10 hours, like that. So we can repeat twice a day, maximum twice a day. We can't repeat more than that. Second, the dose is in single figure. Single figure means 1 milligram, 2 milligram, 5 milligram, 10 milligram, 30 milligram, 60 milligram, 80 milligram, and khalas. It doesn't go to hundreds. The dose doesn't go to hundreds. So what is the message? More potent or less potent? More potent.
More potent.
So if you get question on your exam, compare between first generation and second generation. How you will compare?
Potency.
First thing, potency.
Okay.
Second generation, more potent. Second generation, more potent. First generation, less potent. Then duration of action. Who is long acting?
First generation.
First generation long acting. Second generation moderate or intermediate acting.
Okay.
Mazboot? So that is the difference. If you get question on your exam, short essay exam. Now we come to the mechanism of action. You discussed this mechanism of action with Dr. Ayman in action potential. It acts on the depolarization of the cells. What will happen? That it will close ATP sensitive potassium channel, decrease the potassium conductance, and it will depolarize the cell. When the cell is depolarized, what will happen? Calcium channels are opened. First thing, calcium channels are opened. Second, the calcium vesicles. The vesicles inside the cell that are rich in calcium, they are also opened. So two things will happen. The calcium channel will open, the calcium will come from outside, and intracellularly, the calcium that is present in the vesicles, that will also fuse or they will open. Okay, so when they fusion with the insulin granules, where this happen? In which cells? In the cell membrane of the which cells? Pancreatic cells. Why? Because the insulin is being synthesized and secreted by beta cells. By beta cells. So in bracket you can write with the cell membrane beta cells. Why? Because this depolarization, where the calcium will come in, it will fuse with the insulin granules to push the insulin. If you remember last time I told you, squeeze whatever insulin is present in the beta cells, it will squeeze the insulin, like what we do with the marker, like this, squeezing. Whatever ink is there, we want to push it down. So the same will happen to the insulin. The insulin that the beta cells produced, it will come out and it will act in the cells. Okay, use early stage type 2 diabetes mellitus in addition to metformin. In addition to metformin. So it means it is not a monotherapy. It is not a monotherapy. We will give it in combination with other drugs. And one of the very common other anti-diabetic that we use in combination is metformin. Second one, what is important, needs some islet cell function. If the patient is suffering, as we discussed many times, suffering from type 1 diabetes, type 1 diabetes, no role for oral hypoglycemic, including sulfonylurea. Second one, if the patient is suffering from type 2 diabetes mellitus for the last 20 years, 20 sanawat, and you give sulfonylurea is not working. Why? Because the beta cells in the Langerhans, they are destroyed. Khalas, they are not producing anymore any insulin. Got my point? So we will keep this in mind, that first thing we will give it in combination. Second, we will never use it in type 1. Second one, we will never use it in late type 2 diabetes, where the beta cells are no more functioning.
Contraindication, doctor?
Not contraindication, but there will be no benefit. This is not contraindication, but the patient will come back to you after 1 week, 2 weeks, doctor, my blood glucose level is still high. So that we don't say that this is the contraindication, but the problem is that it will not reduce the blood glucose level. What will happen? Side effects: hypoglycemia if missed meals. If you recall, last time we discussed in the beginning that both for insulin as well as for the sulfonylurea, they are related with meals. I told you we had a patient once downstairs, Saudi patient, mashallah, he said that I take meal once in 2 days. One meal after every 48 hours. After every 48 hours. And he was insulin dependent diabetic patient. And he was doing very fine. Why? Because he used to take one meal in 48 hours. That is really difficult, isn't it?
Yes.
So, but he was managing, and what is the benefit? You need less insulin, because insulin is related with carbohydrate, with your meal. So if you take less meal, you need less insulin. If you take more meal, you need more insulin. Okay? Here the same. For example, the patient missed the meal at night. So better that the patient should miss sulfonylurea at night. Why? Because as we discussed, and you also might have discussed with Dr. Ayman and Dr. Fathi, people die of hypoglycemia during sleep. There are 3 symptoms of the hypoglycemia: tremors, sweating, and tachycardia. When you sleep, these symptoms you cannot recognize. So the patient may die during sleep. So one of the reason patient didn't take food, patient took the insulin or sulfonylurea, the blood glucose level goes down and the patient may expire or die. So that is important. Second, weight gain. As we know that whenever there is hypoglycemia, if you have anyone in your family suffering from diabetes, they are advised to carry candies, halawa.
Yes.
So whenever the blood glucose level goes down, they put it in the mouth. But that is glucose, so glucose will increase the weight. So that is weight gain is there. Second reason, because it is secretagogue, it secretes the insulin and that can lead to insulin causes, again activates our hunger station. It stimulates our hunger station. Whoever is on insulin therapy, the challenge is always weight gain. Last one, cross it, because we don't use chlorpropamide anymore. Disulfiram-like reaction. Disulfiram-like reaction in those who take chlorpropamide with alcohol. So patient is suffering from type 2 diabetes as well as the patient is alcoholic, God forbid. So there is a reaction in the liver that is called disulfiram-like reaction. But because we don't use anymore clinically chlorpropamide, so cross it. What is important for us in sulfonylurea are the comparison, first generation and second generation. First generation longest acting, less potent. Second generation more potent, less duration.
Less duration.
Okay, that is the story of our anti-diabetic medication. Thank you. Alhamdulillah, we finished our pharmacology, and that is the end of your BMS. About your final exam, one exam is on endocrine, that is on